Is it visible now?
Yeah,
Yes,
yeah.
sir.
Please make it full screen.
Now it is okay.
Is it all right now?
Yeah, absolutely.
Okay. Well, let me first thank the API West Bengal chapter for having invited me to deliver this lecture. And I'm talking about approach to chronic diarrhea. So I am talking about a diarrhea which has lasted for more than 4 weeks. That is the definition of chronic diarrhea. And it is a common problem affecting about 1 to 5% of the population. And the common causes I have listed here, the most common being the functional type of diarrhea, the irritable bowels, the functional diarrhea. And then we have a very common problem of lactose intolerance, celiac disease, metabolic issues like diabetes and thyrotoxicosis, inflammatory bowel disease, tubercular, small intestinal bacterial overgrowth, and what is often overlooked is the medications. And then there are other causes, including malignancy. So, broadly speaking, we can divide it into chronic fatty diarrhea, which is because of malabsorption, chronic inflammatory diarrhea, and then you have the watery diarrhea. Watery diarrhea we always see as acute watery diarrhea, but then if you have a chronic watery diarrhea, you could have either a secretory type, osmotic type, or a drug induced. And we all know that there are certain infections which can cause diarrhea for a long period of time, endocrinal causes and drug induced causes. So when we are faced with a patient who is having diarrhea for more than 4 weeks, one of the things we need to sort out is it really coming from the small intestine? Is it the large intestine? Or is it a pancreatic diarrhea? So these are the three main causes for the diarrhea. So certain questions need to be answered. And if you are able to answer these questions, you'll be able to narrow down your diagnosis and target your investigations. Is the diarrhea functional or organic? Is it of a small bowel type or a large bowel type? Is the diarrhea associated with malabsorption? Is it a painful diarrhea, which means associated with abdominal pain or painless? Is the diarrhea associated with bleeding? And that could clearly mean large bowel. Is the diarrhea inflammatory or non inflammatory? So we'll move on to answer these questions. Well, let us first look at the features of functional versus organic diarrhea. Functional diarrheas, for example, the IBS types, are of a long duration. There are less marked constitutional symptoms like fever, abdominal pain can be less but not very marked. Weight loss will not be there. Appetite, etc., is normal. Patient is having no diarrhea at night. And this is a very important question to ask. A patient with functional diarrhea will usually have diarrhea during the daytime, and once the patient goes to sleep, there is no diarrhea at night. Gastrocolic reflex is common, which means postprandial diarrhea is common in functional diarrhea, and anxiety symptoms and associated features more common with functional diarrheas. As compared to this, you can see on the right hand side, organic diarrheas, shorter duration, and there may be constitutional symptoms with weight loss, decrease in appetite, etc. And they also have nocturnal diarrhea. So these are some of the features where we can differentiate functional versus organic. And if you have a patient who has a family history, let's say, of malignancy or a previous surgery, those with a previous history of pancreatic disease, those with thyrotoxicosis or diabetes, those who are consuming alcohol, taking various medications, or a recent antibiotic therapy is very important because antibiotic associated diarrhea or a Clostridium difficile associated diarrhea is not uncommon. So these are situations where you must consider organic diarrhea. So now let's come to the question of whether it is small bowel or large bowel. Well, small bowel diarrhea is large volume but smaller number of stools, whereas large bowel diarrhea there is more frequency, but the stool volume is small. And if there is malabsorption, it can be in small bowel type, frothy or greasy type, without any blood, mucus, pus, and no tenesmus, whereas large bowel diarrhea is usually associated with blood, mucus, pus, and tenesmus associated with the diarrhea. So within the small bowel diarrhea now, there can be those with malabsorption or those without malabsorption. And malabsorption can be clinically defined by the characteristics of the stool with signs of vitamin deficiency and signs of anemia. And the common causes are shown here, which is celiac disease, tropical sprue, parasitic infections, and so on and so forth. Whereas without malabsorption, there is secretory type of diarrhea, which are large volume diarrheas without any evidence of malabsorption. If you look at the large bowel diarrhea now, we have to distinguish between what is organic and functional, and I've already talked about that. And those who have functional diarrhea usually are irritable bowel syndrome or functional diarrhea. The difference being that irritable bowel syndrome is associated with abdominal pain. Functional diarrheas are purely diarrheas without any abdominal pain. And organic diarrhea, again, can be with blood or without blood. With blood, common causes are inflammatory bowel disease, tuberculosis, SRUS, and tumors, whereas those without blood are due to drugs or a condition called microscopic colitis, which is often being missed. Now, painless and painful diarrhea. Well, just to show some examples, celiac disease, giardiasis, etc., are all painless diarrhea, whereas diarrhea in tuberculosis or Crohn's disease will be painful diarrheas. Inflammation or no inflammation, well, if you have features like fever and other constitutional symptoms associated with joint pain, etc., then clearly it is pointing towards inflammatory type of diarrhea. And some of the examples of chronic inflammatory diarrhea are inflammatory bowel disease, infections, pseudomembranous colitis, ischemia, radiation enteritis, and neoplasia. Chronic infective diarrhea. We know that most infections cause short, limited diarrhea, but there are certain infections which can produce prolonged diarrhea, such as C. difficile, cytomegalovirus, E. entamoeba histolytica, Yersinia, and Mycobacterium tuberculosis. So all this needs to be considered. But I think one of the most important things when you are actually taking the history and examining the patient is to take a good history about the medications. And I've shown in this slide a large number of medications which can be associated with diarrhea, which includes the common antibiotics, the antihypertensive agents. Olmesartan is known to cause some sort of a inflammatory type of small bowel diarrhea. Non-steroidal drugs, alcohol is well known, and there are various nutritional supplements which people are taking now when they are going to gyms and all, which can also be associated. And don't forget chemotherapy, immunotherapy associated, because these days we have a large number of patients who are being treated for cancer. So in the evaluation of diarrhea, the one of the other things which I would like to emphasize on, what is the relationship to food? So relationship of the diarrhea with food, if it is occurring after meals, then it is clearly more likely to be irritable bowel syndrome. If it stops with fasting, so osmotic diarrheas are the ones where if you stop eating, the diarrhea stops, whereas secretory type of diarrhea continues despite fasting and even during sleep. So these are the patients who continue to have diarrhea even when they have stopped taking their meals. And I would not go too much into the measurements of stool electrolytes and the osmolality measurements because these are not commonly done. And depending on the site of the pain, one can also have some idea of the cause of diarrhea. If you have a left lower quadrant pain associated with diarrhea, Then irritable bowel syndrome is common. On the other hand, for right-sided pain, then the likelihood of Crohn's disease or tuberculosis rises. And if you have epigastric pain, then the chances of Zollinger-Ellison syndrome, which is associated with peptic ulcer, increases. And during the clinical examination, it is important to look for clues for vitamin deficiency, which I have shown here in this slide. Features of neuropathy, glossitis, ankylosing stomatitis, cheilitis, etc. So, in the primary clinical assessment, I think once you are faced with a patient who has got chronic diarrhea, I think common tests need to be done are CBC, C-reactive protein to look for inflammation, the blood sugar, and particularly thyroid function test. And we are, particularly when dealing with younger patients, always do a celiac serology. Stool examination we often do to look for C. difficile ovocysts and parasites. And if you have any confusion between irritable bowel and inflammatory bowel disease, I think the measurement of fecal cal protecting level can be very useful, and it is now being widely available. On the other hand, if you have a patient with inflammatory type of diarrhea or malignant diarrhea, then we have to go ahead with colonoscopy, ileoscopy, biopsies. For celiac disease, apart from doing the serological testing, we do the upper GI endoscopy and biopsy. And for small bowel type of inflammatory bowel disease, it is recommended that we do not go for barium meal follow through, but we go for MR or CT enterography, and capsule endoscopy, if you have the facility, can be very useful as well. Malabsorption, well, particularly suspect the pancreatic disease, and therefore imaging becomes important here. And for multifactorial malabsorption, you have to consider upper GI endoscopies, biopsy, enterography, and so on and so forth. And for surgical or structural disorders, again, the imaging becomes important, and the imaging is usually MRI or CT. Now, some of the common things which we ought to know is lactose intolerance is very common in the Indian population. Up to 60 to 70% of the population suspect if milk intake is causing bloating, borborygmi, and diarrhea. So you don't have to go for any fancy testing. You can give a simple challenge. Give a patient a big glass of milk, and if they start having symptoms an hour after that, you know that they have got lactose intolerance. But then you can go ahead with hydrogen breath testing and avoiding milk intake. Now, this is one thing which is less often diagnosed, and this is bile acid diarrhea, and usually occurs in patients who have had ileal surgery or gallbladder surgery, and sometimes idiopathic. And this is a sort of a painless osmotic type of diarrhea. And testing for this is very uncommon. CCAT test is hardly ever done. Fecal bile acids can be taken as done, but again, it is not commonly done. And the best is if you have a patient suspected of having bile acid diarrhea, then therapeutic trial of cholestyramine can be very useful. And we've had a whole number of patients who we thought had irritable bowel treated with cholestyramine very effectively. Now, microscopic colitis is one area I would like to emphasize because, again, this is a diagnosis which is often missed, occurs in the form of a painless watery diarrhea, more common in the elderly, in the females, in diabetics, those taking non-steroidals, those with rheumatoid arthritis, celiac disease. Apart from small bowel, you get the microscopic colitis in the large bowel. And the only way to diagnose is a colonoscopy, and the features at colonoscopy will be normal. But if you take biopsies from both the right colon and the left colon, you don't have to do biopsies from the rectum. And then comes the positive diagnosis, which is treated with steroids. Pancreatic diarrhea, I've already mentioned, steatorrhea type of diarrhea, and imaging becomes important. Fecal elastase test is very commonly done and treat with pancreatic supplements. Now, one particular issue, small intestinal bacterial overgrowth, is less often picked up. So, when do we suspect small intestinal bacterial overgrowth? Where the predominant symptom is diarrhea associated with milk intolerance, occurring particularly in those with diabetes or older age. Very common in diabetics, remember. I think this is very important. Always suspect before you diagnose diabetic diarrhea to consider that the patient may have small intestinal bacterial overgrowth in patients who have got bloating and flatulence, and much more common in patients who are taking long term PPI therapy, where there is also a history of response to antibiotics and probiotics. So, the imaging, as I mentioned, is really for pancreatic disorders or to uh, identify conditions where bacterial overgrowth occurs. For example, if you're suspecting diverticula, stagnant loops of intestine, hypomotility of the intestine, those with intestinal fistulas or tumors, or those with ulcers and strictures. So, imaging becomes important there. And treatment of chronic diarrhea will clearly depend on the cause. Certainly, nutritional assessment, supplementation is important, hematinics, and then for specific treatment for specific diseases, all shown here, gluten-free diet for celiac disease, antibiotics, folate for tropical sprue, lactose intolerance, you have to avoid milk, tuberculosis, ATT, then Crohn's disease, for pancreatic diarrhea, it's enzyme supplements, and for diabetic diarrhea, clonidine has become a very useful drug which has been used largely recently. So, in an approach to chronic diarrhea, what you need is a detailed history and a thorough clinical examination. Achieve, try to achieve a specific diagnosis using a minimum of tests. Individualize investigations. And if a disease seems to be more likely, then directly proceed. So, if I suspect celiac disease, I would go straight for serology and a biopsy. It is not necessary, certainly, to do all the tests. So I'll just show you one or two examples of cases where diarrhea was there. This is a young chap with a long standing diarrhea, 3 to 5 per day undigested food, no blood, no pain, no fever, no joint pains. So it is a non inflammatory type of diarrhea, but examination showed that the BMI was low, there was anemia, so there are features of malabsorption, including features of vitamin deficiency. And therefore, there are signs of malabsorption. Stool examination was done just to look for parasites, giardiasis, etc. TTG was high. Villus atrophy was present on duodenal biopsy. You don't require any further testing for such a patient, and this is clearly celiac disease. Here is a patient who is 36-year-old male, diarrhea with occasional blood, 3 months, and a history of right-sided abdominal pain. So as I mentioned, where you have somebody with blood and right-sided abdominal pain, you would consider inflammatory bowel disease, tuberculosis, malignancy, etc. He also had anorexia and a recent fever for 2 weeks, and we did a colonoscopy. So again, for this sort of patient, you don't need the whole load of tests. Straight away, we went in for the colonoscopy, and this is a classical picture of Crohn's disease in the right side of the colon with cobblestone pattern. So this is Crohn's disease. And third case here is a patient who is 65-year-old, so elderly patient, long-standing diabetes with polyarthropathy. So there is arthritis as well, has watery diarrhea with gas and bloating, and for 6 weeks or so. And so this is a chronic inflammatory type of diarrhea. It appears polyarthropathy is there, but what is the differential diagnosis we would think of in such a case? Is this diabetic diarrhea? This is a long-standing diabetes. Could it be drug related, but the patient was receiving non-steroidals? And ideal case, diabetes as well as arthritis, could it be a small intestinal bacterial overgrowth or a microscopic colitis? And lastly, pancreatic disease is more common in diabetics. Therefore, could this be a pancreatic diarrhea? So these are the differentials we need to consider. And in this particular patient, investigation showed that we did the colonoscopy, did right-sided and left-sided biopsy, and this was a microscopic colitis, which was treated with budesonide. Thank you very much. That was just a quick overview of the approach of a patient with chronic diarrhea. Thank you.
Thank you.